My name is Mark George, and I'm here because my name is Mark, and I have a last name with a G, and I was in line by this guy, and he tapped me on the shoulder and said, "You want to come to a nice meeting?" I'm a psychiatrist and a neurologist. I don't know most of you because I've been working for most of my career in brain imaging and then brain stimulation, mostly in depression. But it's wonderful to be here because I think this is the beginning of something big. And some of the things that we've learned in depression with imaging and treatment, I think it's very ripe time. So this is really exciting for me to be here. I'm also very pleased to be here with Tim Brewerton. Is he here? Who actually found me as a resident, made me do my first research poster, and set me on this path I'm going to tell you about. So he's responsible for everything. This is my acknowledgement slide. I don't invest in these devices so that I can call a spade a spade. This is brain stimulation. So it's an overlap really of different areas, neurology, psychiatry, bioengineering, imaging, cognitive neuroscience, psychology. It's a very interesting and fertile area, and I just love working here. This is the most important slide that I have. This is a cartoon of a neuron and a synapse, and I was trained down here. And this is neuropsychopharmacology. It's where all the good stuff is. I write prescriptions all day long, I believe, in medications and drugs. However, what I rediscovered later in my career is that the brain is really an electrical organ. It's an electrochemical organ. And electricity is the currency of the brain. The brain works through electrical signals. With our fascination with pharmacology, we really forgot that basic bit. When we remember that, and the idea that what goes on in the synapse is really designed to either transmit or not an electrical signal, so you can actually stand pharmacology on its head and say pharmacology serves the purpose of electricity. Then the idea of going into the brain and stimulating electrically in specific circuits and coupling that with behavioral interventions and learning really at least has theoretical power. And that's what all the excitement is. And so I want to tell you, now that I've gotten you all excited, kind of what the reality is of where we are. But then I think there's really excitement here of potentially incorporating it in a bigger way. So here's the tools we have. We have ECT, the grandfather or grandmother of electrical stimulation, RTMS, deep brain stimulation, and VNS. So these up here are, I don't know if you can see my pointer here. We have a pointer at all? No. So RTMS is the one that I started when I was back at the NIH, and it's now FDA approved. There are 2 devices out there for treating depression. I don't know, there's 600 or 700 machines now in the United States. It's starting to get covered by insurance. It's making an impact in terms of treating acute depression and maintenance. Deep brain stimulation is approved for Parkinson's disease. You stick a wire in the brain, turn it on. It's really a remarkable treatment for Parkinson's. So far, it really hasn't, it hasn't really translated much into psychiatry. There's a new form where you can actually listen to the brain before you stimulate and stimulate in a way that integrates with brain activity called NeuroPace. They just got approved for epilepsy. And then there's this one called vagus nerve stimulation where we stimulate the vagus nerve in the neck. And it's a proven anticonvulsant. We also showed that it's an antidepressant. It's FDA approved for both of those, but it's not insurance reimbursed for depression. And so there we go. These are FDA approved. And this list down here just grows daily by new ways of actually getting into the brain and trying to stimulate it. So what does that have to do with making my slides go forward? Let me see. Yeah. Yeah. Right here. Huh? No. Yeah, you think it's that simple. No, I know computers. Yeah. Oh, there we go. He did it. There we go. He just get me out of it there. Yeah. He gets to redo the whole. Yeah, the whole thing. Here we go. Keep going. Okay. I'll speed up. And so anyway, TMS. You take an electromagnet and put electricity through this electromagnet, and it creates a magnetic field which passes unimpeded through the skull, and then induces an electrical current in the cortex of the brain. So I call it electrode-less, there's no electrode, electrical stimulation. We're actually stimulating the brain, but we're using this magnetic field to kind of get through and not have to drill a hole in the head. So what about addictions and obesity? So we've known for a long time that you can stimulate certain reward pathways, and we now know that you can use TMS and modify it. So we can induce craving in the lab. We can knock it out with TMS. Those studies have all been done. There are some small clinical trials now in smoking cessation, and an unpublished pilot study that's and these two are linked. What's important in that study is they did 4 cells where they took smokers, chronic smokers, and smoked in front of them, induced craving, and then stimulated prefrontal cortex or not, so 4 cells. The group that got craving induced and then stimulation of prefrontal cortex had about a 50% quit rate at 6 months in a single pilot study, which is remarkable in the addictions area, I think. I come from depression. Very impressive and enough to launch an international trial. This, I think, is going to be quite critical. If the large multi-site trial and this is positive in the addictions, I think the game changes, because if it works in smoking, it can work in lots of other things, including probably food addiction. So watch that one. It's launched now. We're trying to recruit. There's another technology called transcranial direct current, where we actually just put 2 electrodes and pass a very small current through the brain. It's not powerful enough to make your thumb move, but it actually does, like a catalyst in a chemical equation, kind of make a part of the brain easier to perform its function or inhibit another part. So if you couple that with whatever the brain is doing, you can get a small behavioral boost. And I'll show you one of those studies. Deep brain stimulation is extremely invasive, risky, costly, and in terms of addictions and food, there's some people in Europe that may do it, but there's nothing really systematic that you'd want to hang your head on. Vagus stimulation is very interesting, but it's also, in the way that it's done now, likely very costly. So if we put people in the scanner and we do TMS, we can actually show that we can stimulate these cortical areas, and if we go medially, we get very different cortical, subcortical loops, depending upon what part of the cortex we go to. So we can get in and actually modify limbic brain, craving brain, and then cortical regulation of limbic craving brain. So if we know we can do that, how do we use it to treat addiction? So if I wanted to stimulate Dr. Gold and stop his addiction for whatever it is, let's just say you smoke, how would I figure out what spot for you? So I could put you in the scan or show you some smoking cues, and if you smoked, your brain would react differently to that versus that, and then I can use difference imaging, and I could solve the equation, and we've done that. These are the kind of pictures you see in the journals where across a group of 20 people, you pool all the data, you smooth it, and you get a nice little activation area for craving. That's smokers who are craving. You would think that if you stimulated right there, you'd be able to treat craving, right? The reality is that's a pooled image of all of these different individuals here. So each person actually, these little red dots are where that individual actually did it. So if you're trying to find your spot, unless I had a really broad machine, I might miss you. So you might not respond to my treatment. So if we can treat the addictions, the question is, where do we go? And do we have to use expensive imaging like this, or can we develop some rules and general guidelines? What about pain? TMS over the prefrontal cortex can actually cause a reduction in pain. It's anti-nociceptive, and we found that you can actually block that TMS effect with naloxone. Actually, I say it's blocked with morphine. It's actually naloxone blocks the endogenous opiates. We've been using it in post-operative studies to block pain, and there's some effectiveness in chronic pain. TDCS, DBS, VNS don't really have a clinically effective anti-pain effect yet. What about in eating? So I know that I'm hungry by the sensation coming through my vagus nerve. That's what tells me that. And theoretically, I could stimulate those fibers and fool myself and see if we could reduce craving. And so people have done that, actually. These Gooding obese mini pigs. Anybody know these? I'll never forget this. I just love that term, Gooding obese mini pigs. They're these fat pigs that are bred to overeat. If you put in a vagus nerve stimulator of their gastric fibers, they will lose weight over time. You put different food, fat food in front of them, granola bar food, they'll eat their granola bar food. Very interesting. No real work with TMS. And we did a TDCS, is that my time? TDCS study?
You got
Okay.
extra time for Stoltz.
All right. Here's kind of a hint of where the future might be with these technologies. I've talked about TMS, TDCS, VNS. We did a TDCS food craving. So we took 19 women who self-selected for frequent food cravings. So they weren't diagnosed with any disorder, but they did say, yeah, I think I maybe have a problem with occasionally overeating. So they came into the lab, and we put anode cathode over their prefrontal cortex. We kind of made them not eat in the morning so they were a little bit hungry. We put food in front of them, made them crave or not, and then we rated their craving. And the real stimulation here caused a reduction in their self-rated craving. We measured how much they ate when we actually let them eat, but they knew we were watching. We didn't really get a difference in the actual eating behavior. But this just hints that if you do modulate kind of prefrontal cortex, you may be able to have a short-term effect on self-rated craving. Now, whether that would be useful or not in clinical settings, if you couple that with behavioral intervention, I don't know. This is the last study, and this is a segue to yours, so I don't know if I don't want to use your time, but we did an imaging study where we took people who've had gastric bypass surgery, Dr. O'Leary, and we asked whether, what is it that causes people to eat out their surgery or not? So we scanned them and then followed them for a year. During the scan, we actually showed them food craving, and then we asked, then we selected who blew out their surgery and who kept their weight off. What we found was so we had them both crave the food in the scanner, and then we said, resist the craving, stop craving. No difference in the craving images between the people who kept weight off and not. But what we found was that those people who, the resist scan kind of differentiated who was going to stay thin or not. And here's the final picture. So what part of the brain was it? So when they were resisting, you got a big cortical signal. They were actually resisting, and this is the difference image between those who actually stayed thin and those who got fat again. And those who stayed thin had more activity in their prefrontal cortex when they were actually resisting. So you said that it wasn't willpower, but I don't know. This looks to me like it's at least cortical activity that might be involved in this ability to stay out. So I'm around. I'm an idiot savant, as Tim knows, about these technologies, and I'd love to brainstorm with you. But I do think that these circuits, both with imaging and then modifiable by these new tools, are going to develop into probably helpful clinical ways of treating the addictions. And so I'm delighted to be here. Thank you.